I think with IDH inhibitors, the myelosuppression is not as big of an issue when you use a triplet, but there's probably a benefit of sequential therapy as well. While in FLT3, I think the consideration, maybe Max, you can talk to that. In my experience, using azacitidine has been very tough to maintain anybody on, even as we saw with the doublet with azacitidine, it's tough to maintain people for a long time on both without significant dose reductions, and that's even more with, I think, when you add a drug that's myelosuppressive. So what's your approach? Like if you are going to do azacitidine, how would you manage that?
Yeah, it's a good question. So in a patient that is not being transplanted, I think, that I have to maintain on treatment, I think of it almost like more like an induction phase and a consolidation maintenance phase, doing induction to get them into remission, because there is actually primary resistance with FLT3 mutated disease, I think, with venetoclax. But once a remission is reached, I think similar what Dr. Mansour presented with this case, like aggressive dose reductions. Sometimes I even maintain them on the FLT3 inhibitor eventually by itself, and either discontinue the AZA-VEN or give them only VEN plus gilteritinib. So a lot of this is a little bit of a data-free zone, I would say, but I think we all do it in clinic, right? Because we have those patients who are very cytopenic and we don't want to count suppress them. It's so many variables you can manipulate, I think, but that's what I do in clinic.
Yeah, and I think the paradigm in my mind is going to be along the lines of what you said, different considerations based on the subset, but also almost think of it as induction and consolidation maintenance. So you might start with a triplet, but then you go down like to a doublet or a monotherapy after a certain number of cycles. Maybe in the last 5 minutes, talking more about the intensive chemo kind of.
Can I ask a practical question?
Oh, sorry, yeah. Well,
that's me, the microphone.
I did see it.
Before you go to intensive phase while you're doing the AZA, just congratulations on the ascertained data, and I'm starting to see this in my practice, even in the consults in the last couple of weeks. For any of the panelists, in terms of, do you have for a patient not going on trial, do you have a framework for how to pick which HMA you're going to use in terms of IV, AZA, decitabine, or oral? Are there patients for whom one is better than another? And what guidance and how are you managing the oral in terms of the practicalities of management of tumor lysis and induction? So are you doing that outpatient or are you doing that inpatient?
Yeah, I was going to say that's a really great question. So we didn't participate in the study, but what I would say is that I do try now to get oral HMA for patients in combination with venetoclax, just because of that quality of life, I think, perspective. That seems to be a bit better than having to come back and forth. Now, the question of inpatient versus outpatient is very dependent on the patient, I would say, and it may be also in that setting you have to start off with IV, which I've done before, and then convert over to oral if there's some reason you have to justify their stay or whatnot, and you feel like they live too far away, or there's some reason it's not safe to just do it within the clinic space. But from that standpoint, or if I'm not worried they're going to have some increased GI toxicity from doing the oral HMA, I would try to go that path.
Yeah, I would say I've become more a believer in the oral therapy. I would say one thing that I'm sometimes a little bit concerned with the oral therapy has actually nothing to do with the oral therapy, but when you get IV, you actually get forced to see the nurses and be evaluated on, every day during the first couple days of treatment. And I think sometimes in frail old patients where you're really concerned that at home they're not doing well, if you want to treat them outpatient, that's where I still use some IV or sub-Q. But I think otherwise in patients who are able to manage, I think it's a major advantage for them to not have to come in every day, and particular with, I think, continued treatment. I think you mentioned this already, that maybe you give them IV or sub-Q in the beginning, but being on the 35th cycle like your patient was, and having to come in every month, I think that's a lot. Yeah. Yeah, so I do monitor for tumor lysis in clinic. I would say it depends a little bit on how high I think the risk of tumor lysis is. How high the white cell count is, how their kidney function is. I am not as strict with, like, let's say giving the first dose and then 4 to 6 hours later I check tumor lysis labs, but I usually like to see them the next, getting some labs the next day just to make sure.
And I think some of the excitement, in my opinion, about the oral doublet is that it's going to be the backbone for triplets, right? So these FLT3 inhibitors, IDH inhibitors, MEN inhibitors, all of them are oral. So at one point, we are going to probably get to 3 oral drugs to treat AML outpatient, which is, unprecedented when you think about how historically those patients used to do very poorly. Alan?
Just to piggyback out of your point, Max, for patients who I am taking to transplant, I've been leaning towards doing the IV sub-Q with oral ven. In one instance, it's just because I'm so comfortable with it, and in another instance, just to keep a close eye on these patients as I get them safely to transplant after 2-3 cycles. But for orals, it's usually for patients who I'm not thinking about transplant, who this is like a lifelong commitment. This is where I jump on the orals early on. Sometimes for post-transplant maintenance and P53, getting the oral decitabine approved early on will make it easier to initiate maintenance, because I'm still a strong believer of maintenance in some high-risk categories. But that's some of the context vis-a-vis transplant that I put in practice.
Yeah, I think that makes a lot of sense. I would say also when people use oral decitabine venetoclax, I think particularly when community physicians use it, I think it is important to communicate that all the other stuff we do, like checking blood work, tumor lysis point, tumor lysis labs, they still apply, right? Just because you give a patient an oral pill, it doesn't mean like give you the oral pill, see you in 4 weeks for your bone marrow, So I think you still need to monitor them, you still need to take care of them very closely. But at least you cut out the infusion time, which is a big deal for a lot of our patients. We all know how long, infusion takes in theory and how long it actually takes for patients. So I think it still does make a difference.
So in the last couple of minutes, just to finish on intensive chemo, I think in intensive chemo treatment, it's less controversial, at least for now. FLT3 positive patients, 7+3 with a FLT3 inhibitor. I think the area where we get some controversy is what do you do with the NPM1 mutated younger fit patients. And there is data with gemtuzumab, there is data with venetoclax, there is data with CLAG and FLAG. And of course, MEN inhibitors. You cannot talk about AML without talking about MEN inhibitors. So Alice, you are doing a phase 1 trial with 7+3 with revumenib. We presented data with 7+3 and ziftomenib. So how do you approach right now NPM1 fit patients outside of a clinical trial?
Oh, is the question, would I give them a menin inhibitor off-label?
Or would you give VEN or GO or quizartinib? I guess with the QE trial that showed even in FLT3 negative patients, those patients.
Yeah, no, I would say for the gemtuzumab data, I don't feel as strong about that with what's been presented and for that particular subset as opposed to like core binding factor. So I would traditionally treat the patients if they're not going on one of these like multiple menin studies that are all over the place, but would just be standard 7+3 and then monitoring MRD assessments and making decisions from that standpoint.
Max?
Yeah, I'm actually really always conflicted about this question. We also use 7+3 and we also haven't widely adopted GO, although I would say there's some place probably for some patients. The German data, showed there was, reduced relapse-free survival, improved relapse-free survival. So in really young patients where you don't want to take them to transplant, maybe there is a little bit of a role. We haven't widely adopted it either. Then there's the FLAG-IDA data, where really FLAG-IDA led to higher remission rates in the British trials. And I know the British always argue that this should be the backbone for the menin inhibitor trials as well, where we use, still standard 7 and 3. But it was, again, a study that was not powered for that subgroup. It was like a post hoc analysis. So it's always hard what to make out of those. Is it really practice changing or not? We haven't adopted it that yet. We also have a lot of menin inhibitor trials, we usually put those patients on those trials, but otherwise we use 7 and 3 as well.
Yeah, and I would conclude by saying that now we have trials even with quadruplets for like patients who have FLT3 and NPM1. We have 7+3 with midostaurin and revumenib, and we have 7+3 with ziftomenib and quizartinib. So it's really a very exciting era in AML. And with that, I'd like to thank the panel much for the discussion.